I'm Dr. Manal Ali. I am a phoniatric consultant. I'm going to speak about dysarthria. Dysarthria is a motor speech disorder that characterized by any combination of disorders, respiration, phonation, articulation, resonance, or prosody that may result from neuromuscular disorders which lead to weakness, slowness in coordination, and change in muscle tone. Types of dysarthria. There are 6 types of dysarthria. Flaccid dysarthria due to lower motor neuron lesion, spastic dysarthria due to upper motor neuron lesion, ataxic dysarthria due to damage to cerebellar control circuit, hypokinetic dysarthria, Parkinsonism due to damage of basal ganglia control circuits, hyperkinetic dysarthria, chorea athetosis due to damage of basal ganglia control circuit, mixed dysarthria due to damage of multiple motor system. Flaccid dysarthria due to damage to motor unit of cranial nerves used for speech, fifth trigeminal, 7 facial, 10 vagus, 9 glossopharyngeal, 12 hypoglossal cranial nerve. The etiology caused by cranial nerve nuclei lesion such as polio, encephalitis, motor neuron disease, brainstem cerebral vascular accident, congenital causes, brainstem tumors. Peripheral nerves lesion caused by polioneuritis, Guillain-Barré syndrome, diabetes, alcohol abuse, traumatic as in thyroidectomy, neoplastic, idiopathic as in Bell's palsy. Neuromuscular junction lesion caused by myasthenia gravis, muscle disorder such in muscular dystrophy and poliomyelitis. The clinical picture in flaccid dysarthria showed muscle weakness, atrophy, hypotonia, hyporeflexia, and fasciculation. The speech pathology in flaccid dysarthria showed cluster of phonatory incompetence characterized by breathy voice, audible inhalation, short phrases. Cluster of phonatory prosodic insufficiency characterized by harsh voice, monopitch, monoloudness. Clusters of resonatory incompetence characterized by hypernasality, imprecise consonant, nasal emission, and short phrases. Articulatory deficit in bilateral facial paralysis, there is imprecise consonants such as in bilabials and labiodental consonant and rounded vowels. In bilateral hypoglossal paralysis, there is imprecise consonant in tongue tips consonant and vowels needed tongue elevation such as E. In bilateral trigeminal paralysis, there is imprecise consonant such in bilabial and lingual due to failure of apposition of mandible and maxilla. Spastic dysarthria, pseudobulbar dysarthria, is due to bilateral upper motor neuron lesion, corticobulbar tract. Etiology caused by cerebral vascular accident, multiple infarcts, atherosclerosis, vertebro-basilar insufficiency, neoplastic, traumatic, degenerative disease, infection, and congenital as in brain damage, motor handicaps. Clinical picture in spastic dysarthria revealed muscle weakness, hypertonia, loss of palatal and pharyngeal reflexes, exaggerated deep tendon reflexes, and emotional liability and dysphagia. And in speech pathology, revealed cluster of phonatory stenosis characterized by strained, strangled voice, harsh, low-pitch voice stoppage, pitch breaks, short phrases, slow rate, excessive loudness variation. Cluster of articulatory resonatory incompetence, imprecise consonant, distorted vowels, hypernasality. Cluster of prosodic insufficiency, reduced stress, short phrases, monopitch, monoloudness. Cluster of prosodic excess and equal stresses, prolonged phonemes and intervals, slow rate and appropriate silences. Ataxic dysarthria due to damage of cerebellar control circuits, vermis, superior peduncle, lateral hemisphere. It could be a bilateral or unilateral lesion. The etiology, heredofamiliar Friedreich ataxia, idiopathic delayed cortical cerebellar degeneration in old age, symptomatic as in vascular demyelinating disease, neoplastic, metabolic, toxic, infection, and congenital. The clinical picture revealed slow, inaccurate movement, intention tremors, impaired equilibrium, dysmetria, ataxic gait, nystagmus, hypotonia, hyporeflexia. The speech pathology in ataxic dysarthria showed cluster of articulatory inaccuracy, irregular articulatory breakdown, imprecise consonant, and distorted vowels. Cluster of prosodic excess revealed excess and equal stress, prolonged interval, prolonged phonemes, slow rate, inappropriate silences, secondary or compensatory effect. Cluster of phonatory prosodic insufficiency due to hypotonia revealed monopitch, monoloudness, harsh voice, excess loudness variation, plus or minus hypernasality. Hypokinetic dysarthria is associated with basal ganglia pathology and its depletion or reduction of neurotransmitter dopamine, such as in Parkinsonism. Parkinsonism, the etiology of Parkinsonism caused by idiopathic paralysis agitans, symptomatic, caused by inflammatory, toxic, neoplastic, vascular, traumatic, as repeated head trauma, boxing. The clinical picture revealed limited range and force of movement, slow movement, static tremors, mask face, loss of swinging of the arm during walking, and adiabatic rigidity more in proximal and flexors. The speech pathology in Parkinsonism revealed cluster of prosodic insufficiency, short of rushes of speech, short phrases, variable rate, monopitch, monoloudness, reduced stress, and imprecise consonant. Inappropriate silences, harsh voice, breathy voice due to rigidity of laryngeal muscle. In hyperkinetic dysarthria, it is associated with basal ganglia control circuit pathology, also can imply extrapyramidal system dysfunction or cerebellar control circuit damage. There is quick hyperkinetic dysarthria and slow hyperkinetic dysarthria. The quick hyperkinetic dysarthria, which is chorea, myoclonic jerks, Gilles-de la Tourette syndrome, and Cry-du-Chat syndrome. The chorea, it is involuntary static, dysrhythmic, sudden jerky, semi-purposeful movement of any part of the body, increased in stress and emotion, decreased in sleep and voluntary acting, associated with hypotonia. Chorea result in various conditions as in Huntington disease, Sydenham chorea, rheumatic fever. It can also result from certain medication, autoimmune disease, strokes, tumor, or metabolic disorders. Myoclonic jerks, sudden involuntary shock-like contraction of muscle. It involves velum, Pharynx, larynx, palatopharyngeal, laryngeal myoclonus, manifested by momentary voice arrest that clearly audible during vowel prolongation from 60 to 240 per minute. Gildi-La Tourette syndrome, paroxysmal phonatory grunting, harsh voice, throat clearing, facial tics, snoring, echolalia, coprolalia, and palilalia. Cry-Duchet syndrome, congenital syndrome, result from partial deletion of short arm of chromosome number 5. It manifested by cat-like cry due to abnormal laryngeal development. The speech pathology in Korea, characterized by cluster of phonatory stenosis, harsh voice, strained, strangled voice, low pitch breaks, voice stoppage due to laryngeal spasm, slow rates, short phrases, excess loudness variation. Cluster of articulatory resonatory incompetence characterized by imprecise constant, distorted vowel hypernasality. Cluster of prosthetic insufficiency, monopitch, monoloudness, short phrases, reduced stress. Irregular articulation breakdown, cluster of prosthetic excess, slow rate, prolonged phonemes and interval, excess and equal stress, inappropriate silences, respiration, sudden forced inspiration, exhalatory sign, and smacking noises. Slow hyperkinetic dysarthria, athetosis, involuntary irregular, static, slow snake-like movements. It involves mainly extremities, hands, finger, and face on each side. Affect distal muscles more than proximal. It's associated with hypertonia. The dystonia is involuntary static, very slow torsion or twisting-like movement. It involves the neck, trunk, and proximal muscle or extremities associated with muscle hypertonia during movement and normal tone in between. Tardive dyskinesia, specific form of dystonia, appear after long-term use of neuroleptic drugs characterized by abnormal movement affecting tongue, lips, and mandible. In athetosis, the speech pathology revealed respiration, rapid breathing rates, difficulty in taking deep inspiration and control a prolonged exhalation, reversed breathing, decreased vital capacity, involuntary movement of respiratory muscles. Phonation revealed harsh voice, breathy voice, excess loudness variation, monopitch, intermittent voice arrest, inability to sustain phonation. Articulation revealed imprecise consonant, distorted vowels, prolonged phonemes, poor intelligibility. Prosody revealed inappropriate and improper stress pattern, short phrases, variable rate, prolonged intervals. Mixed dysarthria due to damage of multiple motor system, variable according to the disease, and it is a mixture of different types of dysarthria, such as amyotrophic lateral sclerosis showed spastic flaccid dysarthria. Multiple sclerosis showed spastic ataxic dysarthria. Wilson disease showed hypokinetic ataxic spastic dysarthria, and Child-Drake syndrome showed spastic ataxic hypokinetic dysarthria. Thanks.